And thank you for joining this webinar. My name is Terri Scales. A little bit about me. I obtained my professional coding certifications, my CPC, through the American Academy of Professional Coding and my CCS-P through the HEMA organization. I am the National Director of Business Development for Bill Dunbar Associates. We are a leading outpatient CDI consulting company with clients all over the U.S. And today we'll discuss what we at BD&A are identifying as the top 5 documentation risks for healthcare organizations and what they'll face this year. Of course, documentation has become the foundation for compliance, right? Reimbursement, to help with audit defense, and for coding accuracy, right? We'll review these risks, why they matter, and how organizations can proactively identify opportunities before denials or audits occur. But before we begin, I'd like to review our disclosure statement. This information, of course, is based on our experience working with healthcare organizations across the country. Because regulations and payers require continue things to evolve, always verify your coding and documentation guidance with your CMS, your local MAC, and your other individual payers. But I'm excited to discuss these 5 documentation risks affecting healthcare organizations and how those risks impact compliance and reimbursement, and give you practical ways to reduce them. I'll introduce BDA's complementary preliminary analysis at the end, and I'll explain how it helps organizations identify documentation and coding opportunities. But one of my goals today is to encourage everyone to think about beyond coding accuracy alone, right? Documentation is not simply a coding issue. It's a compliance issue. It's reimbursement issues. It's quality issues. And it can be a risk issue. Documentation, it all starts there. So let's start by discussing the current healthcare environment. There's several forces are converging, simultaneously. Healthcare continues to face staffing shortages. We are operating with fewer resources than, we prefer. Artificial intelligence is rapidly being integrated into documentation workflows. I think we're all experiencing that. Increased payer scrutiny regarding documentation support. Diagnosis validations becoming more and more important. Medical necessity. Our chart reviews are based on medical necessity. And coding accuracy. Medicare Advantage plans remain under intense federal oversight regarding risk adjustment practices. And then, our increasing denial rates. Compliance teams are expected to do more with fewer resources. Documentation deficiencies are expensive. Initial denial rates have reached an all-time high. It's at 11.81% in 2024. I'm sure it's higher now, but those are the stats that I have. And currently, processing a clean claim is estimated to cost about $6.50. So that's just a clean claim, while reworking a denial claim averages $57 and may cost as much as $181 just to rework one claim, that's been denied. Perhaps the most concerning statistic is nearly 65% of denied claims are never appealed, meaning that revenue is permanently lost, right? Documentation integrity is one of the few areas organizations can improve to reduce denials before they occur. And that staggering number at the bottom of the screen here, that healthcare organizations spend approximately $18 billion annually attempting to overturn claim denials. That's staggering. So Everything begins with documentation. When documentation is complete, accurate, specific, then the coding becomes more accurate. Then everything else falls into place, like the reimbursement, again, medical necessity, or appeals, hopefully they go down, or it's easier to appeal a claim. And then compliance, that makes them happy when documentation supports the codes that you're billing. I always say one phrase, we often hear is, if it wasn't documented, it wasn't done. I would actually even add, if it isn't documented clearly, it may not be defensible. So let's jump into the first risk that we've identified. We all know that artificial intelligence, it offers tremendous potential. We all agree with that. AI can improve efficiency. It can improve coding patterns, documentation patterns. It can assist providers with documentation overall, However, AI is not a compliance solution. AI cannot replace clinical judgment. We know that. It cannot independently determine medical necessity. We've found that it cannot validate whether a diagnosis is truly supported by documentation. And one of the biggest risks we are seeing is organizations assuming that because documentation was generated or assisted by AI, it is somehow, accurate, it's complete, but we're finding it's not. In reality, AI-generated content can introduce unsupported diagnoses, conflicting statements, duplication of information. We've even seen that it's missing specificity. Diagnosis codes, they take it down to this specific part of the body, the side of the body. We are already seeing examples where AI-generated documentation includes diagnoses that were never evaluated during the encounter. We've seen documentation like say the patient was from Michigan, they're visiting the provider, and the abbreviation was MI for Michigan, and the patient was diagnosed with an MI, myocardial infarction. So now that patient is logged with their health insurance with an MI. So, from a compliance perspective, this creates audit exposure. From a coding perspective, it creates inaccurate code assignment. As a coder, we're seeing that. From a reimbursement perspective, it can lead to both overpayments, but underpayments too. We are all experiencing a rise in payer denials. That's for sure. We're seeing that for unspecified diagnosis codes. So unspecificity is really causing havoc with denials. This is a growing challenge for rev cycles. Payers reject or deny these claims because unspecified codes often fail to demonstrate, medical necessity of a service. It's suggesting incomplete provider assessment or vague documentation based on, AI knowledge. So the mitigation strategy is not basically avoiding AI. Is it validating AI outputs through experienced coding professionals? Do you have coding professionals there that look at the documentation? Do you have CDI specialists, compliance personnel, providers? Are they going back and looking at their notes? So important human oversight remains essential with AI. AI isn't eliminating medical coding. We know that. Kind of just making our jobs shift a little bit more to auditors now. Kind of fundamentally reshaping our profession. The role is shifting away from repetitive manual chart entry and towards auditing, denial management, and compliance review. Human critical judgment remains essential for interpreting clinical nuances, those complex diagnoses, in, our evolving payer regulations. The second risk that we're seeing, provider education remains one of the most underutilized compliance tools available. Most providers generally want to document appropriately, right? They all want to do it right. They've gone to school for many years and been the top of their classes. They want to do it right. The challenge is that documentation requirements continue to evolve. E&M guidelines changed in 2021 and then again in 2023. It needed to happen. We all know that. And risk adjustment requirements continue to evolve. How often you educate your providers might need to be based on documentation and coding accuracy, based on chart reviews by your providers. Those that maybe score well or have an accuracy above a certain threshold, we've seen 80% or 90% as a threshold might only need to be on a 6-month review or even on an annual program, depending on your organization. Those below the threshold might need to be every quarter, until they get above the threshold. If your organization is large and it's difficult to get in front of your providers, maybe consider outsourcing. The ROI might be worth, taking a look at that in the long run. And, if you don't have your current staff that can do chart reviews and the education, maybe think about considering outsourcing that. Companies can typically give you an ROI ahead of time to let you know that. Without continuous education, providers often continue documenting the same way. They have their templates, they have their nuances of how they document. This creates documentation variation across providers, right? Every provider's templates look different. It creates coding and inconsistency. And so it makes, the audit vulnerability. So most importantly, it creates a situation where organizations do not realize opportunities are being missed. They don't know what they don't know. Practitioners don't know. Maybe they should be documenting something if they're not educated. The most effective education programs are not generic. They are specialty specific, right? So a cardiologist might not receive the benefit of education if it's directed to another specialty like orthopedics. It's got to be driven to their specialty. The most effective programs are data-driven. Show your providers their own bell curves, with a comparison to the national benchmarks. Let them see if they undercode or overcode, then educate on their actual chart findings. That is one of the reasons BD&A emphasizes education connected directly to chart reviews and their results. Providers are more likely to change behavior when education is tied to their own documentation patterns. And when they see it in those bell curves, how do they compare against their peers? Typically that helps them understand, are they undercoding or overcoding? Number 3, many organizations immediately think of compliance risks when discussing documentation. However, documentation deficiencies also create revenue risk. Undercoding, what we just were talking about, remains extremely common. We all know that there are providers that say, I won't get in trouble if I code in the middle. So, missed office procedures remain common. I meet with practitioners that might not know there's the difference in coding a simple versus a complicated IND. Because there's coding definitions. They don't know those. Typically, when I meet with providers. Modifier opportunities are frequently overlooked. Should you place this modifier on this code? Should you not? Is there a CCI edit? E&M level opportunities are frequently missed. So the financial impact is often significant. One missed opportunity may not appear meaningful, but when those opportunities occur across hundreds or even thousands of claims or encounters annually, they add up substantially. Our compliance leaders should remember that compliance is not simply preventing overpayments. Compliance also includes ensuring that organizations are appropriately reimbursed for the services actually provided. So, again, talking about undercoding. Number 4, moving right along here. Adjustment, risk adjustment continues to be one of the most scrutinized areas in healthcare. Or RAF, right? Or risk adjustment factor scores. They are entirely dependent on documentation. A condition cannot be coded if it's not documented. It cannot be supported if specificity is missing. When we do our chart reviews, we frequently identify chronic conditions that are clearly present, but inadequately documented in the notes, so we can't capture it. We also identify conditions documented without sufficient support. Both situations create that risk. One creates underreporting of risk, the other creates an audit risk. One way to help ensure your documentation is up to par for HCC coding is to include, there's an acronym, MEAT, kind of a weird acronym for healthcare, MEAT, but monitored, evaluated, assessed or addressed for the A, and treated. Just one to kind of remember there. Risk number 5, audit activity continues to increase. Commercial payers are auditing. We know that, right? They're doing it on without even, asking for notes. Medicare Advantage plans are auditing. Government agencies are auditing. Everyone is auditing. You should be doing it internally. We all know that the payers are using highly sophisticated automated tools, like AI. They are scanning claims and looking for coding errors. Then here it comes, the denial, in your door. The next step is the hospital's appeal the process. A very timely process for a hospital system. Their goal is, in their AI, is to predict the claims that won't be appealed. We're seeing the insurances are trying to predict those, or where underpayments will go unnoticed. Their AI has identified your trends. Modern AI-enabled analytics allow payers to look back across years of claims and see patterns in how hospitals respond. They can see appeal timelines, overturn rates, and even how often providers do not pursue appeals because the reimbursement dollars don't justify the work. So I've heard of limits of dollar amounts that hospitals put on themselves of, do we challenge this amount or not? According to a Becker's Hospital review, we've seen that the cost per denial jumped from roughly, $44 in 2023 to more than $57, in 2024. From my previous slide, that's 30% increase, $44 in 1 year to $57 in 2024. That's significant. So you can really tell AI on the payer side has really increased on the, our compliance and the audit exposure. The most common audit findings we see when we are reviewing documentation includes lack of diagnosis specificity. Diagnoses are becoming so important. Missing documentation support. Inadequately, having medical necessity documentation. And we're even seeing, modifier issues. Modifiers are so important, and coders can help grab those for our practitioners because it's hard to understand when you need one and when you don't. These findings often originate going back to our very first slide, documentation deficiencies, right? Rather than coding deficiencies. It all starts with documentation. This is why documentation integrity should be viewed as the first line of compliance defense. Organizations that proactively identify documentation weakness are far more successful in defending audits. So as we conclude, I'd like to leave you with several key takeaways. Documentation remains the foundation of compliance. It remains the foundation of reimbursement. It remains the foundation of audit defensibility. The organizations most successful in 2026 will not necessarily be those with the most technology, right? With the big EMRs of the world, or the most sophisticated, but they will be the organizations that combine technology with documentation integrity, provider education, compliance oversight, and continuous monitoring. You have to involve that provider education too. I've got a QR code on the screen of how you can reach out to us at BD&A if you'd like. I'll have it on the next couple screens. We do a complimentary preliminary analysis and can give you an idea, how your documentation looks. Is it meeting the coding guidelines? Identifying clarity for where you stand in 2026 with your documentation and coding is with maybe doing a spot check, or I sometimes call it a health check. I want to leave you with something that is simple to consider. We call it the BD&A preliminary analysis, or the prelim. Most organizations know they have opportunities. Few organizations know exactly where those opportunities exist, but our prelim, it evaluates documentation quality, coding accuracy, compliance, exposure, the revenue integrity opportunities, and we can even take a look at your risk adjustment performance. We identify areas of strengths in this prelim, areas of risk, and potential education opportunities. And most importantly, we provide in this prelim, actionable recommendations. The goal is not simply identifying the problems, right? The goal is to help organizations build improvement strategies going forward. Where can you actually identify those? So I want to thank you for your time. We'd be happy to answer questions and discuss how BD&A's prelim can help your organization identify, those documentation risks, again, reimbursement opportunities, and compliance vulnerabilities, before they become a significant problem. Feel free to reach out to me. Again, my name is Terri Scales. There's our phone number on the screen here. Email us at info@billdunbar.com, or, just put your phone up to the screen here, go to the QR code and just put in your email address. That's totally fine too. So look forward to hearing everyone. Hope you found the 5 areas interesting and makes you think outside the box. Have a great day.